So today we're going to demonstrate how you can do two things, awake intubations using a flexible endoscope and or the CMAC, and how to do some topical anesthesia. And we're also going to introduce the CMAC 5 scope, which is a video endoscope, flexible endoscope that plugs into the CMAC video monitor.
So I'm by no means an expert, but driving the scope is fairly straightforward. You have one control here that you operate with your thumb that bends the scope anterior, posterior, or up and down, obviously, depending on the relation to the patient. There's also a couple ports here that Travis is going to be able to talk about, but there's a suction port, and then there's an port for injecting medications here.
The most important step in this procedure is preparation. As with all patients requiring an airway, IV access, supplemental O2, and monitor is required. Next, you want to have a plan for secretion management. This includes suction on, ready at the bedside, and the administration of an anticholinergic agent. We like glycopyrrolate at 0.2 milligrams IV because it doesn't really have much cardiac effect. The problem is that it takes about 10 to 15 minutes to begin to work, and occasionally, if your patient's in extremis, this is not an option. Next, you want to draw up your drugs. This includes the sedative you're going to use for the procedure and your RSI drugs, including a paralytic, drawn up and ready to push once you access the airway. You want to have your plan for anesthesia lined out. This is typically done with different preparations of lidocaine, including viscous and 5% paste, and also liquid lidocaine for nebulization and atomization. We'll go over that in the video. You also want to have a backup airway plan. Now, you've already gone down the path of a difficult airway algorithm, so the next step is typically a cricothyrotomy. So you want this set up, and you want the neck prepped, and you want this at the bedside. You also need assistance. Your hands are going to be on the scope and in the patient's airway, and you want to have people around to hand you things and to hold the patient's hands, perhaps even consider using soft restraints. And finally, you always want to consider calling help. This is a difficult airway. Having RT at the bedside is very helpful. They know bronchoscopes very well. They can hand you stuff and help you with the airway. And then also calling surgery, ENT, or anesthesia is not a bad idea, given that the next step is typically a surgical airway. The next step in the procedure is to have a plan for anesthesia, sedation, and analgesia. This is achieved with topical methods that we'll go over in the video, using different lidocaine preparations. And there are some airway blocks you can do as well, but these get to be a little complicated, including transtracheal and glossopharyngeal nerve blocks. We like to keep it simple. Also, you want to have a plan for parenteral sedation. This is typically performed with agents or doses that protect the airway. The whole goal here is to keep the patient's airway reflexes protected until you secure the tracheal intubation. I like to use ketamine. I use a low dose, about 0.25 milligrams per kilogram, so about 25 to 50 milligrams IV in an adult. Some people like Ketafol, and others prefer to use Versed and like it's for reversibility. All of these are perfectly appropriate options so long as you protect the patient's airway. Next, you really want to make sure that you have your RSI drugs pulled up, including your paralytic, ready to push as soon as you access the airway. So the first procedure we're going to review is an awake nasal flexible videoscopic tracheal intubation using a flexible Videoscope, the Storz 5 scope. First, we'll go over methods of achieving topical anesthesia.
For anesthesia, topical anesthesia, we're going to use three different solutions. We're going to use 4% lidocaine without epinephrine, which is, I call it the airway lidocaine. We're going to use 2% without, and then we're going to use 5% lidocaine paste. In addition, we have two devices here. We have a nasal mucosal atomizing device, which allows you to atomize the lidocaine into the nasal mucosa, and then we have what's called a pharyngeal atomizing device. So first thing we're going to do here is we're going to take 2 cc's of 4% lidocaine and squirt it into my nose.
The use of lidocaine pastes in jelly is also a really great way to achieve this. Some people recommend putting the viscous lidocaine or paste on a nasal trumpet and inserting it. This will not only help with anesthesia, but also provide lubrication for passage of the endotracheal tube.
Not bad. A little bit sour. Okay, and the second thing we're going to do is we're going to nebulize 4 cc's. Wow, I can already feel that. 4 cc's of 2% lidocaine without. The next thing to do is to, there's a couple of different ways you can do this. One of the things I like to do is use this 5% lidocaine paste and or a mucosal atomizing device. But if you take this stuff and you just put it on the back of your tongue, I think that's got a good flavor to it actually. Is that flavored?
Experiment.
Is it spearmint? Yeah, tastes good.
The next thing you want to do is insert an endotracheal tube into the nasopharynx using a 6-0 to a 7-0 tube. This will not only act as a guide for your endoscope to get to the cords, but it will also make it a lot easier to pass the tube over the scope into the airway once you've accessed the trachea.
I'm inserting a 6-0 endotracheal tube. This is the absolute smallest tube that will work with this device. And I put a little bit of the 5% lidocaine jelly on it to provide some lubrication and anesthesia. And I'm just going to insert it like I would a rhino rocket. So you're going to insert it directly anterior, posterior.
Okay, that's good. That's really good right there.
Okay, so for the purposes of this video and Clay's comfort, we're not going to insert the tube all the way. But normally I would recommend inserting the tube so the end of it is in the posterior pharynx. It'll just make this a lot easier. So you're going to take the endoscope and you're going to insert it through. I just can't really. There we go. Getting a little bit of friction just because it's
from the tube.
There it is. Okay, so we're in the pharynx. There's his epiglottis. A little bit of fogging, but you can see the cords.
We're going to pass this thing through the cords. My cords are not anesthetized right now. No. So if you, at this point, if he puts that through my cords, I'm going to have a cough reflex. So if you wanted to ablate that reflex, then you take that right there, or you use this port right here to spray lidocaine through the endoscope onto my cords from this position. At that stage in the game, when you have the endoscope like right over the cords, and you know you're going to go in there, you want to, I would have already given the patient some ketamine or possibly some Percet, or I don't use Percet, but ketamine, 25 to 50 milligrams for an adult, and they would already be kind of like sort of dissociated or sub-dissociated, and that's really, really helpful in this setting, and it kind of takes away all the discomfort that I just went through, which was minimal. At that point, you drop the endoscope through the cords all the way down to the carina, and then you push, your sedative and even your paralytic if you want at that point, and then you just pass the tube right through the nose over the scope. We've shown that that's something you can do to an awake patient. This is a patient that you don't want to go through the mouth. Angioedema, big abscess, whatever. Facial trauma as well.
Next, we are going to demonstrate the oral approach using the flexible endoscope for either diagnostic purposes such as foreign body identification or removal, or for interventional purposes like laryngoscopy and intubation of a patient who may have an anatomic deviation such as a parapharyngeal abscess or a structural lesion, and it acts as a visualization adjunct to direct or video laryngoscopy.
The one thing we're going to do differently here is we're going to use this thing. This is one of the coolest devices ever. Like I said, this is that malleable stylet with the mucosal atomizing device, and Mike's going to squirt this on my posterior pharynx to assist with some anesthesia of my posterior pharynx as opposed to like my nasopharynx and oral pharynx. That's not flavored as well as the other.
All right, there we go. There's the cords.
It's a hell of a lot easier than
Pull
through the
out.
nose.
You can get a good view of the epiglottis.
Swallow, Clay. Sorry. If you can. Yeah. Okay. Code.
There's the epiglottis. Looks normal.
have to put it somewhere. You put it just right here.
The next thing we want to demonstrate is conventional direct or video laryngoscopy in a completely awake patient. This can be very useful in a patient that you do not want to paralyze until you are certain that you can access the airway, and it is something that is remarkably easy to do.
Typically you're going to use a little sedation, but you can do it completely awake, video or direct laryngoscopy, and in a patient that you don't want it paralyzed. You want to protect their respiratory reflexes. You can actually tube them with,
All right.
while they're wide awake. Typically you're going to use some sedation, but with a topical anesthesia you should be able to visualize the cords at least enough to pass the bougie.
You doing all right?
Uh-huh.
All right, we got a view of the cords. I don't want to pull up too hard because Clay is not sedated whatsoever. But, I mean, I have at least a grade 2 view, and I think I could easily turn that into a grade 1 view with just a little bit of laryngeal pressure.
Yep.
And certainly if he were a little more relaxed.
And that's enough, even a grade 2 view even is enough to pass a bougie if that's all you got. And then at that point, once you get a bougie in there, at that point you can actually push your paralytic confidently.
Great idea.
So we've covered a lot of ground today, from preparation to topical anesthesia, sedation principles, and the use of the endoscope, and also direct and conventional laryngoscopy using awake techniques. This is a wonderful tool for emergency physicians and is, as you can see from the video, very accessible to everyone. All of us are facile with video laryngoscopy, and now with the advent of technology allowing us to have video endoscopy at the bedside, it can be a wonderful adjunct. It might save your butt and might even save a life or two along the way. So thank you for your time and enjoy.